Tēnā koutou katoa. Welcome to tonight's webinar. It's unbelievable that we're almost halfway through 2021 already. I would like to acknowledge our nurses, particularly today, as they stand together across New Zealand. Then, moving on to this evening, we are fortunate to be joined by Maria, who is an expert child and youth clinician. Maria is currently the Clinical Director at Health Connections, providing specialty primary healthcare to children and young people. Her clinical roles have included Clinical Director of the Youth Hub, HealthWEST, recipient of the Vodafone World of Dierence Scholarship for Work in Youth Sector, Chair of the Society of Youth Health Professionals, Aotearoa, New Zealand, Board Member of Thrive, and National Advisory roles. Then, with our other hats, Maria is also an Honorary Lecturer at the School of Nursing, University of Auckland, and Guest Lecturer with the School of Nursing, Massey University. One busy lady. Tonight, Maria joins us to share her knowledge on youth health, assessment and engagement, including strengthening our knowledge and skills in using the HEADS framework. Exciting! And I'll now hand you over to Maria for this evening. Thank you.
Thank you. Kia koutou, everyone. It's a pleasure to be here virtually. It's our whole new world, isn't it, this virtual world? But really pleased to be here talking to you about skills for working with young people. As Cathy said, I am a nurse practitioner and my passion is children and young people. And I've been working for the last 20 odd years in New Zealand, working alongside young people and pushing and driving different ways of working with them. So look, hopefully I'll be able to answer all your questions and your queries today. So if I can't, I will make a note of them and get back to you, but we'll endeavour to do what I can do. So let's start because time suddenly flies on. We're after 7 o'clock now and welcome to everybody from your homes and places that you are at. So today what I aim to do is to just look at why we would take a youth health and development approach to working with young people. And I'll explain that a little bit more, what I mean by that. But it is a little bit different to adolescent development. It is around youth development, which is an important factor when we're working to get better outcomes for young people. I'll then explore what the HEADS framework is and when to use it and why to use it. So if you're expecting anything else, please text me, message, and we will look and see if we can include that as well. Okay, so the why. And I know you can't answer, but I would like you to think about who said this, at what period of time was this said? And I'm going to get silent entries. I don't know if anyone's messaging, and some of you may well know. But actually, this quote, I see no hope for the future of our people if they're dependent on the frivolous youth of today. For certainly all youth are reckless and beyond words. When I was a boy, we were taught to be discreet and respect our elders, but the present youth are exceedingly unwise and impatient of restraint. And I remember when I first saw this, I thought, oh, it's the early 1900s. But actually, it's 800 BC. So youth have always challenged society in terms of their behaviour. And if you think about what the purpose of adolescence is, it is to move from a child to an adult, and they're practising. So why do we need to work with young people and differently? I think, one of the things we often see in society, young people are seen as problems, but actually, if we turn that around and look at what they can contribute, they do have their own resources, and they are resources to be developed and not problems to be solved. And this is Karen Pittman. She's a great, if ever you want to look up any youth development resource, she's a great resource. And I want you to think about recent media stories that you may have seen in the headlines. And I think, like you'll probably see things like this. 1 in 20 young Kiwis addicted to booze, shot youth taking illicit drugs, alcohol blamed for rising youth assaults, all negative imagery. And it's often what gets reported about youth. But there's another side to this. And this is the side we often don't celebrate or acknowledge. But young people are amazing. They do stand up, they do lead, they do take charge, and they do participate in society. And they are the future and do need to be encouraged. And I think that's what I want you to think about when you're working as clinicians and busy clinicians and you see that next young person, is how you can work alongside them and build on that strength rather than focus on the negative. I think one of those things around New Zealand society and most societies, that young people, there's a confusion as to who young people are. And I'll just put some definitions up. Who defines young people as 10 to 24-year-olds? Youth are often defined as 15 to 24 and adolescents 10 to 19. So we've got this discrepancy about who adolescents and young people are already. There's no firm parameters. We have social definitions. I don't know about some of you, but I do know some of my colleagues who are from Pacifica. They're not adults until they have their children, and the cultural and social definitions do impact. And some societies have rites of passage going from childhood to adulthood with their rituals around puberty, which can support and inform and support young people's development. But actually, we do have a lot of confusion. And then we have the physical causes, the physical changes of puberty and the legal definitions, which we will explore a little bit more. But actually, you can see already who are young people and what defines them is always already multi-layered. I think this is an interesting, the New Zealand laws and statutes for youth. What age can young people leave school? We've got 16 years. What age can they have sex? 16 years. What age can they vote? 18 years. And I know there's been some push to reduce that. Drinking and smoking, 18 years. Student loan, 25 years. They cannot get a student loan unless they're 25, independent of their parents. So again, a little bit of a mixture there around what defines a youth, an adult. So we have these layers and different definitions of who are young people, and we also have legal definitions of who they are. We also have the health issues that young people face, which I'm not going to go into full details. Normally I'd put a slide in here, but I think I'm probably preaching to the converted who know what the most common issues are. Most young people are healthy, and I think that's something that we all know. They are generally healthy, but they do have difficulties in areas around their health. And the difficulties tend to be around mental health. I hope you can see all the slides because I've got about sexual health, risky behaviour and violence, and alcohol and other drug use are generally the issues they have problems with and difficulties. I think the other thing about this is that when young people are experimenting with these behaviours, it's a rite of passage, so it can be quite common. It's when they become ongoing, persistent problems, persistent behaviours that they become a problem. Most young people report that they want to make healthy changes, they want to lose weight, they want to quit substance use. And I think, this data, a lot of it has come from the Youth 2000 series. So Youth 2000 series is the Auckland University survey that's been repeated in 2000, 2002, 4 times now. I think the last time was 2019, and they're still producing reports from it. So they've surveyed young people across mainstream school, but also young people out of school in alternative education. What's impacting young people currently, and you might find different areas, different issues that are impacting young people in your community, but there are things like social media, bullying on social media, online porn and gaming issues, and they're having significant effects on the mental health and emotional health and well-being of young people. Access to healthcare is always a barrier to young people. Often adolescents coming back to those social definitions, when they're 15, 16, they're seen as being able to look after themselves, and parents are busy with younger children. So often getting to see a doctor they have to make a fuss, and it's actually embarrassing. And I'm sure in rural areas, you've got another layer of a barrier, which is access. I know you've got school-based services up there, but actually if you're out of school, what support do you get? If you're in courses, there may be some support, but it will be inconsistent. I have to say, from the Youth 2000 data, there have been improvements since 2001. But what we're seeing is the impact of the housing, socioeconomic status of families impacting more greatly on young people's health. Terry Ann Clark has just done promoted something. Actually, she's done a study on the effect of poor housing on the health behaviours of young people, and she's a Northland nurse who has got some great resources. So we do know these are very real and very current health issues that our young people are facing. So just when you're working and engaging with young people, understanding adolescent development and youth development is really important. I think one of the things, it does inform how you conduct your assessment, and it does inform how you manage and plan for the treatment and the interventions with the young person. Firstly, I'm going to look at your physical development and the things you'll know about. I'm not going to go over everything, but we know about puberty and the physical changes young people go through. I think cognitive development is an area that is really important to understand. When you're working with young people in early stages of cognitive development, they're very concrete thinkers. So giving them concepts about, for example, managing their asthma will be really difficult for a 10 to 13-year-old to process with multiple complex sentences. It needs to be very concrete and very black and white, and be very short sentences and very clear communication. Now, the challenge for this is, while I'm saying early cognitive development is 10 to 13, we can have some 17-year-olds who still fit that early cognitive development. Physically, they may be well in the late period of adolescent development. Socially, they can be in the late period because of their behaviours and how they're socialising, but cognitively, because of developmental issues, it might be trauma, it may be exposure to violence, it may be learning difficulties, they can still fit into that early development. So that's a challenge for us as clinicians, to understand where they are and where they fit. And to be fair, as young people go through these stages of cognitive development, they can move backwards and forwards. What makes them move back is stress and alcohol and drug use, because it creates it impacts on their development, and it impacts on their brain development particularly. But actually, I do think even that late stage, you look at some of those and you can think, actually, some of our adults are in that late stage of cognitive development, still need support as well. But I think this is really important to think about when you're doing a youth health assessment, to look at where they're at, and to be really sure that you know what stage they're at. So not only are you looking at things like their physical development, TANA staging, but looking at their cognitive development, how they're processing their thoughts. Major development issues in these stages, probably not new to you. I'm sure you've all seen them. I think, one of the things we've always talked about with development, am I normal? Is that early development? Who am I and where do I belong? And where am I going is the late stage. I think one of the things we've always talked about is the separation from parents. But what we do know about adolescent development is that they do still need those parents in that later stage of adolescent development. They're still as important as in the preschoolers. It is still important to connect with them. And it might look different to your preschooler, but it is really important that they still need to be connected to their parents. Okay, and the main concerns these young people face through this period are listed here. Again, it's their anxieties in that early stage around body shape and comparison with peers can continue through as well. Where they belong, I think maintaining identity and who they are, and this is where we might see gender issues come through as well, and where they go in and developing some self of independence. Now, some of the young people who might have experienced adverse events through childhood may struggle in to get to these late stages and still fluctuate in that middle area, trying to understand where they belong and where they should be. Now, this information sits across, sits in the background to your assessment. And we've probably all done this in our training and now any reviews, but I just thought it's really important to revisit and to look at it. Brain development, I think one of the things that we really need to think about when we work with young people is how the brain develops. And we do know that maturity and frontal lobe connections are not completed to 20-something. I'd actually push it out to 25. There's a lot of evidence saying that a lot of those neural connections are not completed. The frontal lobe is important for planning and judgment. You add another part of this, you add alcohol into young people's judgment, and it really does go AWOL. So I think, the adolescent brain, I'm not going to go into all the brain development, but it is really important to think about where they're at and the reasons, and to understand the reasons why they make impulsive choices, where they don't plan ahead and think about consequences when they get into that car that somebody's stolen. They're in the moment, living in the moment. I'm not making excuses for their behaviour, but you can see why they've had some adverse events. Their developmental, physical and cognitive development is delayed. They've got alcohol or drugs on board, and they've confronted with their peers who they're making choices that are not always great. They're going to do things that don't make great judgments. So just what I do reassure you with is that some of those frontal lobe connections can be supported. And that's why I think the adolescent period is really important to change and strengthen those neural pathways with some good connections rather than negative connections. So that it isn't a lost cause. This period it is a time and an opportunity for change. So adolescents are a work in progress, so don't give up on them. And sometimes they do make the same mistake 3, 4, 5, 10, 20 times, but eventually they do learn. So just to summarise, early stages of adolescent development is self-focused, moving away from childhood through to middle to late, where they're integrating more complex ideas. And you need to think about these implications for your practice at every stage when you're working with a young person, because it does tailor your approach. Okay. I don't know if there's any questions, just a pause. I'm going to go from adolescent development now to youth development. And I have this lovely slide by Bob Blum. He is a paediatrician and a researcher, American guy, who has actually been over here and presented. And he and some of his colleagues, Bob Blum isn't one of the originators of the heads assessment, but Goldenberg and Cohen, who were also doctors over in the States, found that they were struggling to engage with young people and were only scratching the surface of what their problems were. This guy is the guru of youth development now, and actually he's looked at 4 pillars that which if are in place will create a strong grounding for good pro-social youth development. When these pillars are missing, that's when young people do veer away from normal youth development and struggle. And it's a really simple model. And I think, if you can overlay this, have it on your wall in your clinic, just as a reminder, young people need adults who care. Young people need adults who are crazy about them. And I stress adults. And I often get young people who, when they're stressed around their mental health and they've got low mood and some self-harm behaviours, and you ask who can they talk to? They'll often identify a peer. But what I'm saying to you here is you need to be identifying an adult who can help them, an adult who's not in those stages of development that will struggle to process and to follow through on things. So if they've got parents who they're not connected to parents and they're disconnected, if they have, the adult can be a school teacher, it can be a sports coach, it can be a community member, but they do need somebody. You do need to identify somebody who cares about them and is involved in their life. And ideally, it's the parents. They need a place to be, a place to belong, a place to congregate, a place not without adults, but to where they can do it safely, and it's a supported place. They need activities to participate in. And when I say activities, they need pro-social activities. What we have is, and you'll know this, we have gangs, which are great. They do mirror the youth development model, but they do it in a different way. They do it in a negative aspect. So they've got people who care about them, but they want them. These people want them to do something bad. They've got a place to belong. The gang house, whatever it is. They've got activities, but they're not pro-social. They're anti-social. So activities are really important for young people. So when they're not at school and they're not participating in any sports, music, drama, whatever, it's something to flag up. Contributions. They need to be able to contribute to something other than themselves. So that could be family. And one of my questions that I ask a young person is, when did you last make your mum or your dad or your grandma or your auntie a cup of tea? Something as simple as that can actually see if the young person is engaged in family life. And you'd be surprised how many don't do it. And you can find something else that's probably more pertinent and not, to your population, but it is something to think about. If a young person isn't contributing, then there is, it's another pillar. And this is often the weakest component for our youth. They may have adults that care and places to go and activities to participate in, but often they're not involved in that contribution to society and something bigger than themselves. And it can be a challenge, but where you can get that support from for these young people as youth workers, they do this bit really well. It's their job. But I think this model is simple structures. When you're doing your heads assessment and you're formulating your plan, think about these 4 points and how that impacts on them. So when they have all those points in place, they're actually quite resilient young people, and they've got the capacity to bounce back from bad times. And you'll see that in some young people. There are internal resiliencies that I have no control over. Interestingly enough, it is about blue eyes and blonde hair make people more resilient, which is ironic, but it's a biological fact. But there are those external factors that build resiliency as well, and that's about environmental. It's about home. It's about place to belong. It's about activity to participate. Builds resiliency. Young people take risks. I'll challenge most young people, and I think you can all think back to your own adolescent days and your adolescent behaviour. And I challenge you to think about what risks you took and what situations you got in, and potentially you got out of them quite safe because you were resilient, but some young people don't. But risk-taking assists in identity formation. So they are going to be taking risks. You're not going to get away from that. Protective factors, or the risk, those factors that we talked about, do buffer that risk and insulate against it. And that's where those 4 points come in. The PCAP model comes in. The people, the community, the contributing, the activities and the places. So, yeah. So I think I've probably covered these. Protective factors work by reducing risk, reduce the level amount of risk, and reduce personal susceptibility. So I'll give you an example of that. So, I'm seeing a young person, I'm doing a HealthWEST assessment, I get to the drugs and alcohol, and I'm working with a young person who's really engaged in school, achieving academically, got goals for the future, but might go out partying at the weekends and smoke marijuana, cannabis, and drink alcohol. And it will balance out, because all those pro-social behaviours will balance out the risk-taking. Where I get concerned with risk-taking is when you've got a young person who's doing that and actually might be smoking some marijuana before they go to school to cope. They're not achieving. There's some disconnect from whānau and family, and because they're not getting on, or there's some family separation, or there's parents fighting. Though that young person who's using that cannabis and marijuana to self-medicate to get through the day is the person that I worry about. So you've got to weigh up the pros and cons, what's protecting them, what risk they're at. Because you could spend a whole session just saying, don't do this, don't do that, and it's not going to change anything. It's not going to change, and they're not going to listen. But actually, the protective factors are what we need to build around young people. It might not be you that do it, but it's referring on to an agency that can build those protective factors, like church youth groups, like youth centres, like activity-based centres that might be in your community. And I can't answer to. I have been up to Northland, and I have worked, been to Hokianga and that area, and I have seen remoteness of areas, so that might be a challenge. So young people might turn to online support as well for activities. And that's something that's beginning to emerge, is how good is online connections? We know about the harmful effects of social media and the harmful facts of gaming, but there is some emerging evidence around gaming, for example, that it can be a resiliency, or it can be a buffer to confrontation in the family by going on and playing a game for half an hour, because it dissipates the tension that might be between the mum and the son, for example, because they're fighting, they can't come to a resolution, but by separating and doing something different breaks that cycle and that behaviour. But again, it's about monitoring the gaming and how often and how frequent and what the content is. But that's just a little bit about protective factors in youth development. It's important to understand what change young people are going through, consider what might happen next, so you're prepared for those kids, young people who are in early cognitive development, that that potentially they're going to get into the next stage of the development, be able to rationalise and negotiate and debate things. It supports how youth development does explain their actions and thoughts, and it guides and plans for groups or individuals. Okay, any questions? I'm going to now go on to the HealthWEST assessment and how we use the HealthWEST assessment. Any questions that are burning that we need to answer? Nope. Okay. I've talked a little bit about the history and why it was developed. And I think one of the things that sort of surprised me, I was, like Kathy said, I got the Vodafone Fellowship quite a few years ago. And one of the things that wasn't being used was the HealthWEST assessment. And it wasn't the whole purpose of the Society for Youth Health Professionals, but it was about raising the awareness of working differently with young people that we were trying to do. And actually, I did a little bit of a search the other day, and I found HealthWEST assessments all over the place, Starship guidelines, your Auckland called regional pathways. I'm sure it's in your regional pathways as well. And that's incredible to think that it's gone from nobody using it to actually it's been integrated into mainstream practice. I do think just in terms of the HEADS assessment, it is, you have to give it a go and you have to trial it and you have to, we'll go through the questions, but when you get to that point of the questions, I always started, when I first started, I had a set of questions that I'd used routinely and got comfortable with. So there's different ways of doing it. And by no means the questions I'm going to go over are comprehensive. This is my interpretation of it. There's bits missing that you want to include that I'll talk to, but I think, just having that overview from row to go of the HEADS assessment will give you some tools to use tomorrow. So setting the scene is really important. Consent and confidentiality, not, again, I'm preaching to the converted, this is something you do day in, day out. But I think one of the things I would like to stress with this is we do need to repeat this, a bit like, thinking about the brain development, thinking about cognitive development. Young people forget about consent and confidentiality, so don't assume you can do it once, particularly around the 3 harms, and I'll get to those. It's a process and it's got to be developed, it's got to have the impact developmentally. So I think, use the consent and talk about it, but also think about parents and consent and where the parents are. One of the things I encourage you to do when you're seeing young people, and you can decide what age, we were talking about this today with some GP registrars, about what age do you see a young person on your own. And that's, again, it comes back to the developmental stage. You could have a 17-year-old, but they could have some, significant development delay that you would probably never see that 17-year-old on their own without their parents because of the consent issue. But then you might have a 12-year-old who's socially well developed, physically well developed, and is taking some risk behaviours that fit in that adolescent at young person's age range, and you might want to see them on their own. But I think with parents, and I've heard people call this parentectomy, but actually we need to work with parents as much as we do with young people, because actually we need them on board and we need them implementing plans that we're supporting the young people to do. But actually we also need to respect young people's rights as well, and that we can see them on their own. So it's setting up the process to complete a HEADS assessment. And I can hear some people going, but we've got short appointments, we haven't got time to do all this. But you've got a process where you've got a relationship with this child and young person over a longer period of time to do this in. So make sure you just discuss consent, make sure you just discuss confidentiality, and explain to parents that if the young person's at any risk, you're going to address it with them and not keep secrets. Some guidelines around consent and competency to consent. I'm sure you've all heard of the Gulick competency. It actually was went to the High Court in the UK about a woman who took a doctor to court around him prescribing her I think a 13 or 14-year-old daughter, got the contraceptive pill. Since then, it was overruled, and the young person had rights because the doctor had documented that they understood what they were consenting to and the effects if they didn't give them contraception, the outcome, potential unwanted pregnancy and things like that. So from that, some guidelines were developed, and the Fraser guidelines are readily available online. And if you don't know about them, I'd encourage you to look at both these, the competency and the guidelines, to guide you. But if you deem, and it's up to us as clinicians to document and report that they're competent to consent, and you can use the Fraser guidelines or Gulick competency, and there's some bullet points you can cover. They've understood what they're consenting to, they understand the implications or the impact if they don't get the treatment that they need, and the consequences of not getting the treatment will do harm. So really clear, but it still can be ethical, and it can still pose ethical questions for us as clinicians. But I think it's, if it'll do harm by not treating, whatever that treatment might be, then that's something you need to think about. I think just one thing I'll add in here, because I noticed we've got quite a few primary care clinicians on. One of the things we've just noted recently is that young people's ability to enrol with the doctor, we've always assumed that it's 16 or 18 or whatever, and I actually had that checked out recently, and actually you can actually enrol a young person under 16 with your practice if you do, again, they fit the competency to be able to consent and enrol. Parents might not like it, but I think it's just a useful fact to know, because sometimes we don't always know what their rights are. Okay. I think the important thing about parents, and this, don't worry about reading this, but this is, I think I mentioned it earlier, there's a doctor did an amazing heads assessment, but actually, saw the young person with the mum, then separated them out, then went on to ask about sexual health and stuff like that, which was the rubbing point for the mum, and really concerned the mum. So it's really important to make sure that you're open with the parents. And I've worked with parents as well, and I've used the heads assessment with parents to get them to think about their young person and what they might be doing. It's always a useful thing to use, and not many people, you probably haven't heard that, but actually going through the heads assessment with parents from their perspective, what the young person's doing, is a really good tool to use. But just for your information, this actually was managed quite well, but I think it's just something to be aware of. How you set up your consult is really important. So we've talked about consent, we talked about ability to consent, and the confidentiality and the 3 harms. And this is the part that I think is really needs to be explicit every time you talk to young people, because they do forget. And I do get them to, I do ask them when they talk about harm to self, I ask them to give examples, because that's my language and professional language there. But it's about, have you ever thought about hurting yourself, rather than harm, because it doesn't always mean anything to them. But I think it's really important that we're clear about that, and we're clear that actually if they do disclose any of that and do talk about any of that, and what you're going to do with that information before you go into it, because that's where we end up with issues when we're not clear. And it's really important to revisit every time you see a young person. It doesn't take long. And actually what I'm finding more and more now is that young people have got this, they know it. If they've accessed services, they're beginning to understand this because it's repeated so often. Okay, so brief whistle stop tour of setting the scene. But I think that's really important to set the scene. I don't know how many of you use the heads, and I'm sure there's a few of you that have. So, but I think, in terms of using it, what we've got is this acronym, which stands for this, but you might see many other additives to it. So you might see a C at the front, which adds in culture. You might see something about an extra S for social media and, online things. I'm trying to think what else I've seen. I think it might even need to see a C for COVID, what the impact of COVID's had on our youth population as well. But I think, for me, around anything you do, this is a good baseline to work from, and culture is woven through all the questions, and that culture is defined by what the young people. It might be youth culture, it might be a linked to their ethnicity, it might be a gang culture, it might be something else, But I think it's about knowing who you're seeing, knowing your population, know what's impacting on your population, and you'll pick that up from local media information and also some self-report from young people. But this is a baseline to use. So I always default to this and add things in when it's relevant. So when you start, be yourself. Young people can spot it if you're not genuine. Be caring, approachable, good at listening, professional, strengths-based. Strength-based, I'm sure I don't need to do this, but actually, it's about praising. You sometimes struggle to find something to praise, but when I get somebody who reports that they've used condoms, I'm like, yay, fantastic, let's celebrate what they've done well, even if they don't manage to do it all the time, so just make sure that there's some positive praise there. I think the other thing as well, and the strength-based approach, I had a mum and their son come in, and I could see that I was watching as they walked down the drive, and I thought, that young person doesn't want to be here, being dragged in by mum. So, I did set the scene. I talked about, this is your time. This is about, opportunity for you to talk to a health professional. You're not a child anymore, so I'm going to see you on your own as well with your mums, and we'll get some opportunity to have that private time to talk about things that are important to you and talk about consent and confidentiality. And I said, you've also got an option to be here. And he said, well, I don't want to be here. So I let the boy go, which the mum wasn't very happy about. But actually, it worked really well, because the next time the mum came, the boy came in because he had some control. And it's so the strength base is about, giving some control back to the young person, but also praising what's important, what that's important to them. Open-ended questions you're all aware of, and I think that can be a challenge for us, because when we're doing a clinical assessment, we want to gather as much information out as possible, and we don't want too many waffly answers. We want to hone in on the issue. But with this psychosocial approach, we want to keep the questions open-ended and gather information. Try not to intervene every part of the head's assessment. And I know I do it sometimes. I slip into it, and I just, like I was saying, I was doing this GP registrar training today, and I saw the GPs doing it. They were honing in about solutions. The way to get to, once you've gathered all the information, that's the purpose of the head's assessment, is then you work together with the young person, or the young person, their whānau, or parents, to look for solutions. Do ask, even if you know the answer. If you don't ask, they won't tell you. And I'm amazed. For those who've used heads, you'll know that how open young people are. I'm absolutely floored sometimes at what they share with me. Be aware of your assumptions. Don't assume anything, and that comes really at the forefront around gender orientation, using gender pronouns, using with your girlfriends or boyfriends or partners, please don't assume, because a young person looks the way they do or comes in the way they do, that, we've got to make sure we're clear of our assumptions. It's hard sometimes, but I think, I do give it a go if you've never used it, because it does work. Okay, we're getting on to the nitty-gritty now. So you'll see heads assessments, and I'm using the word heads assessment because that's what we use. It isn't a validated tool, and I think you just need to know that from a clinical perspective. It is a psychosocial interview or a psychosocial conversation, and I think I can't stress that enough, because I think that's one part that has taken a life of its own. And I've actually been to court where I had a disclosure of sexual abuse with a young woman. And I was quizzed around this in court because I used the word heads assessment, which is what we tend to use. So, so I think from a clinical perspective, it isn't validated, but it does bring out the information to inform a better approach to intervening with young people. So home is about the home situation, family lives, relationships and stability. That's what you're trying to get out of talking about home. The acronym was developed in the theory that home was a safe place and an easy place to talk about to young people. But if home is not a safe place and there is some family violence and it is a scary place, it might not be an easy option to start with. And you might not know that until you start asking questions. And I've sometimes started with home and never got any further because of the trauma and abuse that's going on at home. Not always, it doesn't happen all the time, but, so that could be all you end up covering. But I think it's important to understand what you're trying to get out of it. It is about what the situation's like, what the family lives, and what the relationships are. And the questions there are not, some of them are open. It's like, what are the relationships like at home? I tend to turn that around and say, who can you talk to at home? Who do you tell something really private to at home? So you use language that you're comfortable with, but this gives you a guide of what to cover. Are there fights at home? I might turn that around and say, who makes the rules? What happens? What are the consequences? What happens if you break the rules? What does that look like? The consequence. What is a consequence? Who do you argue with most? So it's like you sort of eliciting a snapshot of what's going on at home. People moving in and moving out of home are significant as well, and moving house is significant as well. And parental separation. Again, nothing new, but it gives you a snapshot. Okay. Education and employment is around getting a sense of belonging, and this is about you building that picture around their pro-social connections. Do they belong at school? Do they feel like they fit in? What are the relationships like? Asking about who their friends are and what their names are helps. Changes in performance. Now, I don't know if anyone's ever done this, but I do it quite frequently. And it's as an action point when young people are struggling at school, because often they come in, they're not learning at school, their behaviour is bad, they've got mental health problems. Fix them, please. Actually, it's something that parents can do, is go back to the school and say, look, can we get a school report? Can we look at that and get the parents to bring the school reporting so you can look at what's going on. Then you can come up with a plan around the school and support the parents to go into the school to meet with the guidance counsellor or the pastoral support or the dean, so you're working like that. If you've got problems at school and they're not going to school, I've done plans whereby, getting into school for 9 o'clock is really stressful, but actually finishing school is a good achievement. So I've negotiated with schools that they'll start later, but finish school so they get that sense of achievement that they've got through the day. So there's lots of things we can do here. So when you're asking these questions, you're trying to pull out information that you can do something with at the end. And it might not be all your work. It might be that actually you could refer to a guidance counsellor to do this, but it is important to think about what you're trying to elicit out of these questions. Changing schools, and again, changing multiple schools. There's never time to change peers, particularly at high school. It's a really stressful time to change school. And these are broad statement questions, but you can hone in and get a little bit more focused. I'm going to keep going because I can talk a lot about these. Eating and exercise, how they look after themselves, and eating and sleeping pattern is good here. And sometimes here, when you start talking about eating and sleeping, you end up going on to mental health because you've started pulling out information that's pertinent to their mental health. But these are just, sometimes, asking about, do these eat breakfast, lunch and dinner? I'll say, who cooks dinner at night, and who makes dinner? Who do you eat with? Because one of the things we do know from some of the 2000 surveys is that families that eat together stay together. It is a social interaction. And that is a good factor to know about the young person you're working with, if they sit down and eat together. But if parents are out working late at night and they're not home and things like that, it's important. Changes in weight and dietary habits are sometimes things that can be sensitive, particularly if you've got young people who are overweight and are embarrassed. But I do think, it can be a worry for them. So it's important to think about how you ask that sensitively. And sometimes that can be about asking parents as well if they're concerned about their young person's weight. Exercise as well. So there's some of the things that will guide you if you do have concerns about your person's overeating and undereating are really important. Okay. Attitudes and peer relationships. This is about the social and interpersonal relationships and skills and their risk-taking behaviours. And I also ask, the important thing is, what do you and your family do for fun? And the problem is you've got to really think about this. If you are eliciting lots of nothing answers, then you've got to start honing in about something that can be more strength-based. The screen time in video games I've touched on recently, and Terry Fleming is a good resource to look at, and the Adolescent Health Research Group and Youth 2000 series is a good place to look about the evidence that's emerging about some of the gaming that's important. As well. And also there's some great resources online for young people's mental health. There's some of the questions. I'm going to keep going because I think sexual health and mental health tend to be the ones that we struggle with most of all. Drug use and cigarette and alcohol and risk-taking behaviours. Again, how much, how often, when, where, and has it changed? And who else uses in the family, and how do they get access to them? Because that's the challenge. When it's coming from home, it's really hard when it's the norm at home to change some of their behaviours. So it's just understanding what the picture is and then understanding what they want to do. So I often use this, particularly for males. You've got this young man, 15-year-old, he's playing rugby at school and club rugby or something, and I might be out of, because I don't know if they don't play at 15 or older, but they want to play rugby, but they're smoking and drinking and they're, overweight, and developing that that incongruence around what they want and what they're doing can be a good motivator for change. And that's where it comes into your plan about, so you want to play in the first 15 at school, but actually you're doing this. Is that a problem for you? Is that impacting on your fitness? It can actually be a motivation for them when you get to your plans. Sexuality, and you're trying to understand their knowledge and their understanding, their experience. Also understand their gender identity and sexual orientation and practices. And there's some questions there that are really straightforward and can be really useful. I find, if I'm working with LGBTQI, that if they've got any connections to any support services like Rainbow Youth, that they're the ones that are teaching me and what language to use. But if young people are unsure and they're questioning who they are and their gender identity, they're going to struggle if we actually present with their gender is their biological sex. So we do need to be careful. For younger younger adolescents, I think, it can be really hard to have these sexual health conversations. So I'll often start with, oh, did you go to puberty? Did you and your parents go to puberty? Because most schools do a puberty session. Not all parents get there, or did you do puberty at all? No, and I'll use puberty as a segue in. I'll use sexual, are any of your friends having sex? Have you, so you go into third party to broach the subject as well is really useful. Sexual relationships, not a word young people use. Are you having sex? Are you sexually active is not a word people use, but I know it does get used. A young person, a colleague of mine asked, are you sexually active? And the young woman thought for a minute, she said, no, I just lie there. So, we've got to be careful about our language. Safe sex, what does it mean to you? And if they are using contraceptions, please raise the roof and praise them for doing it, because I think that's really important. And also it's really important, I also check around if they're being forced into doing something that's sexually that they didn't want, and have been touched in a way they didn't want as well. And, and it's sometimes when you get those disclosures, it's hard to hold it, but it's just that acknowledgement that it's a really difficult conversation to talk about and praise, just praise them for actually broaching that conversation and being open with it, and acknowledge that, and just acknowledge that it isn't okay, and that we will talk about that and come back. It's really hard. Sometimes it's too traumatic and you've got to stop there and deal with that. Other times you can keep moving because it's historical, but it's coming back to about what they want to do with that. Safer sex and STIs, and there's a whole gamut of misinformation around that, about how you can get pregnant. I get 14-year-olds, 15-year-olds come in, I've had loads of unprotected sex, so I can't get pregnant, I think I'm infertile, and things like that. So it's just, reassuring them and talking about, facts, and giving them access to facts and information at their level. And this is why it's really important, where they are in their cognitive development, because otherwise it's just going to go over their heads. Suicide, self-harm, depression and mood. What you're looking for is the risk of mental health problems and strategies for coping, and their support systems that are available. And, I'll say, I often use the mood score, 1 out of 10 saddest you felt, 10 out of 10 the happiest you felt, what do you feel today? When did you feel? 10 out of 10, explore what was happening then. Was it a birthday party? Was it out with their friends? They had a good day? Was it mum and dad went on holiday? And then 1 out of 10, or down at the bottom, and often not many people report 1 out of 10 unless they're currently suicidal. That, what was happening there? What was going on? Who was around? What did they do to not do anything? How did they manage that? What strategies? What did they think of? How did they distract themselves? So it's always good to understand that. I think often when I talk about low mood or sad or whatever, often I get the anger bit is what I get is often a sign of low mood, because they're on a short fuse, and anger is the emotion that we see. And it's really important to explain that to parents, that they can have low mood, but actually what you're seeing is not low mood, you're just seeing an angry young person. Looking at where they're at, I'm really explicit if young people are down, using the third party. Sometimes people feel when they feel down, they feel like hurting themselves or killing themselves. Have you ever felt that way? If yes, what did you do? When did you do it? I also talk about, do they know anybody who's completed suicide, and the closeness of that? It's that red flag. How close were they? Was it a family member? Was it a peer? And things like that. So there's some of the questions that you can use. I'm just keeping an eye on the time. And that they are, what's amazing is that young people will open up around these things. And if they're opening up to you, because remember, you've set the scene, you've talked about confidentiality and what you're going to do with this information, it's often because they want you to help them. They might be not always happy if you need to talk to their parents about things, but actually it's often a cry for help. So please do not be afraid to ask these questions. You do need to be prepared to deal with what the outcome of these questions bring. And that might put your data pot when you're trying to do a clinic, but actually it is important to ask. And this is where, I talked about those alkaline drugs to relax, calm, cope with the day is a real red flag as well. It feels very odd not having the answers and questions, but I will keep going. Okay, risk-taking behaviours in the environment. really important. You know, I suspect that rurally there's potentially a lot of car driving by young people without licenses. Again, I shouldn't be making assumptions, but I am. But I think that, you know, that there is potentially that. You need to look at the news and see that. And I know from friends, my son's friends who live rurally, that was something they drove very young, whether they had a license or not. Wearing seatbelts, riding bikes without helmets, things like that. It's, you know, just to understand what risks they're taking. Risks around in their neighbourhood. You know, it's if they don't feel safe, get them to go out and do things. It's not going to happen. Knowing, you know, they know really what's going on. They do know where the gangs are. They do know, you know, what's going on. And I really feel sad, and I'm not saying that a young person should carry a knife, but we do get young people who bring knives to school, and often because it's getting to school is a risky time for them, or going home from school. It doesn't make it all right, but it's understanding why they're doing it, and then, you know, what you can do to protect them. And if they're in school, often it's a good pro-social, it is a protective factor, but, you know, still there can be risk. And feeling safe at school is a really important thing as well. We have more control around schools in influencing what goes on, because there's systems in schools that should be there to protect young people if they're not safe. And that can be, you know, be brought up by parents going to school and asking to talk to people and getting, you know, systems in place. But in the neighbourhood, it gets a bit harder. But community police officers are there as well. And it's just around knowing what your community is and what supports are there. So you gather all this information, what do you do with it? And I think the challenge for us as clinicians is not to keep intervening at every level. And I've done a little bit of that just to give a context for what you can do with some of that information because of the nature of how we're doing this presentation. But actually, it's about then coming together and looking at with all the problem lists, what the strengths are. And I often start with the strengths. So what's going really well is, you know, you are, despite what's going on at home and all the pressures that parents, mum and dad are separated and they're fighting a little bit, you are going to school, and that's really fantastic. And you're staying at school and you want to achieve, and you've got some goals when you leave school. What's not going so well for you is that there is this family stress, and you're actually using alcohol and cigarettes to cope, and you're actually taking some risks with your partner, and you know, so you're having unprotected sex, you know, so you then go to that. So and it's, you know, so these are the things that I think we should be working with. What do you want to work with? And it's then putting it back to the person, and that will depend on where, you know, what response you'll get will depend where they're at in that period of cognitive development. Because if you've got a young adolescent, they're not going to have the skills to negotiate and look at what they want to do. So it might need to be led by you. So pulling together what's going well and pulling together what's not going so well, and call it, you know, strengths and goals or something. You know, so it's like what they want. Strength. You've got to keep that strength-based approach with it. Check what they want to talk to their parents about. So, you know, if I have the luxury of seeing a young person with their mum or their dad, they'll both before, then seeing the young person, I always bring the parents back in and agree with the young person what we're going to talk about and what we're going to share. If there is a need for referrals, then who, you know, so coming back to the parents, agree who's going to do what and what include goals for the young person with the family whānau and the timeframes for that, what you're going to do, what you expect the family whānau to do, and what you expect the young person to do, and put some timeframes around that. And they've got to be those SMART goals. They've got to be achievable. There might be a long list of things that need to happen, but you've got to start with one or two things, and then come back to the PCAP model. You know, that young person whose asthma is poorly controlled, another education and another asthma action plan might not have the outcome you want to achieve if you don't address some pro-social activities. So getting them to join a club or go to a church youth group or participate in a school activity might have a better effect in compliance with or concordance with their medication, because they'll want to do that. They'll want to participate in sport, but they've got no motivation because they're not well supported in their youth development components. It's really hard for them to actually embrace and implement some of the strategies we might want to implement. You might pick up with there's lots of onward referrals to do, ACC forms to complete if there's a set abuse disclosure, and it might be that you want to park the ACC because they might not want to do it now. Checking addresses is really important if they're going to do it and parents are not aware of past abuse, and there's no current safety issues. Making sure that the address information goes to is to the young person, not to the parents, because ACC will send a letter. But I do sometimes I will encourage ACC forms because they might not want to access counselling now, but they might do later on in life, particularly when they get to that later stage of development. They can see the impact of what that abuse has had on them. So, and that's an example of an intervention. But there'll be other referrals potentially to mental health services and what that looks like. Document, and again, nothing that you don't know. Yeah, so reducing risk where possible, building on resilience is an important component of a HEADS psychosocial assessment. So it is a listing all the information out. You could end up with a problem list as long as you are, but if you're in general practice and you're in it or a school-based clinic, you've got that opportunity to bring that young person back and work on things a little bit at a time. My challenge to you is to work with what the young person works with, which can be a challenge for us as clinicians because we're so used to directing what we want to do. But as long as there's no harm, there's no immediate risk around mental health, no immediate risk around sexual health, or no immediate risk around drugs and alcohol, then it's a process, moving that young person through those stages of development and also working at their pace. Okay, I'll put this back in just to remind you to use it. I cannot underestimate the simple model that works. Positive ongoing relationships are proven to be protective factors in most areas of young people's lives, and that's what's important. So getting parents and young people into the same room to deal with their issues is a real good outcome. If you can do that, you're there. Just to summarise what I've covered today, generally, young people are healthy and thriving. However, they're compromised their well-being by some of the factors there: low income, poverty, family violence, compromised mental health of parent caregivers, and AOD use of parent caregivers. Adolescence is a time of growth and development, and nothing stays the same. And I do reiterate that with young people. You feel like this today, tomorrow you might not. In a year's time, you're going to feel different again. And it's just they don't have that longevity that we may have as adults, so don't see it, they're living in the moment. So it's sometimes for us to remind them risk-taking is normal, and sometimes it's hard to sit with that risk as clinicians, but it is normal. And as long as it's not extreme and they're not in immediate danger, it's going to continue. So it's about building their resiliency and building those protective factors. Global and national research shows that young people experience one or more health issues, and as young people are living, and this hasn't been an ongoing thing for a long time, we've got young people living with chronic health issues that might have not survived into adolescence but do now. That has another layer to it, and we haven't covered young people with disabilities or with chronic, significant chronic health issues, but I think that's something that has another layer to it, but it still does work. HEADS does still work with those young people. So if you're working with young people, you've got this opportunity to identify an issue and seek early intervention. And early intervention does work, particularly as school refusers. Getting into that early adolescent phase with school refusers does have better outcomes. When they get to that middle to late area of adolescence with school refusal, it's a hard yard. It's often the pathways out of school, unfortunately. So any young person who comes and is brought to you because the parents say, I can't get them to go to school, in that 10 to 13, that's the time to get in and change. So, for example, talked about this, I've done all that. So I think knowing your community and where to go for further help is really important. There are some agencies, I know in Formulating, you've got the, I can't remember what it's called now, Youth Hub. Is it a Youth Hub? Or, I can't remember. There's Formulating Youth Space. I know there's some youth spaces in Kaitaia. So, it might be that they're not local and not accessible, but a phone call to them might link you into something that is local. So making sure you do have those connections is really important. The end. 7:57. Whoa. Are there some questions? I can't see the questions, Kathy. So
that's all right. I've got a couple of questions, Maria. That was fantastic. Thank you. What a beautiful energy you have around you. We need to take all our young children to you. Give you all our youth. So someone has asked, is there a condensed version, or what would you recommend in an appointment in 15 to 20 minutes with a young person?
Is there a condensed version? Now, Sue Bagshaw, some of you may have heard of Sue Bagshaw. She has got a condensed version that she has done in GP training to use. So there is, and it is, if you Google Sue Bagshaw, you might find it. It's the GP training. I think it's on, I'm sure she did some work with the College of GPs as well. For nurses, SYHPANZ, Society of Youth Health Professionals, I think they've got some of the resources online as well. But I think about what you want to get out. And if you look at the PowerPoint, you'll see what are you trying to get out of those components of the heads. I think you can soon ask a question for like home. Who lives with you at home? Who makes the rules at home? Who's the safe person you talk to? You'll get a good picture there of what's going on at home quite quickly. So you can condense to 2 or 3 questions for each section. If you know you can't. If you know you can't ask those sexual health questions that might unearth a bigger problem, but you flag it for your next appointment to start with that. Do you know what I mean? So if somebody's coming in for a Gardasil immunisation, that's where you can do your sexual health thing. So you can do it in sections. Do you see what I mean? So if they're coming in with immunisation, you might not dive into, but the Gardasil you would, because you're talking about sexual health anyway and protection. So it's a real opportunity just to focus on the sexual health component. So condensed Sue Bagshaw, how do you can have a look at what she's put down as 2 or 3 questions that you could use in a short consult. What was the second part? Make sure I've answered it.
The second part was about timing. Do you know, in terms of how long, sort of 15, 20 minutes, what do you sort of when you're booking out a day, how would you pre-plan this for time?
I would pick 2 or 3 questions out of each section and just use them routinely and see if you're getting enough information out of those questions, that you're asking. Review Sue Bagshaw's if you can access it. If I can find it, I can share it. I'm not quite sure how we can share that, but I can talk to Mobile Health and look at how we do that. But SYHPANZ and Sue Bagshaw, the collaborative, are 2 places to go for some good resources around youth health.
Someone's asking if you use Youth Chat.
The youth chat, that's the Auckland University one. I haven't used it because it doesn't interface with MedTech or a patient management system. So it is really useful and it is good because it does give you a summary. And I've used, we had a tablet with the heads assessment on to young people. We trialled it with young people filling it in before they came in. So you've got a little bit of information to look at, to work from. And I know some people have done that on a paper basis, but again, it all depends on the literacy of the young person, because the tool we used was the headset with the questions being asked as well as it being written on the screen. And there is the e-chat, I think, is really good, but I haven't used it because it doesn't interface and doesn't support what I'm trying to do in my practice. But it is a really useful tool.
Thank you. When do you refer a young person to health psychologist?
Okay, so I don't know what support you have. So I would look at young people with mild to moderate mental health problems, referring to either internally, if you've got people who do some mild to moderate interventions in your practice, or to the school guidance counsellor, or to a psychologist, depending on, and I suppose it depends. You've got different levels. If you've got somebody with a significant eating disorder, you might be looking more at a psychologist than somebody who's got low mood, where a counsellor might fit. Where you've got young people with acute mental health problems and high risk, you'd be looking at referring straight through to your secondary mental health. And I'm not sure with your rural situation what that looks like. But what I do know is all mental health services, secondary mental health, they've got a duty clinician, and it's always really useful to case review anybody you're concerned about if you're trying to decide, is this secondary mental health or is this primary care, mild to moderate mental health interventions. Now, the problem with interventions is cost sometimes as well. So I think that's another issue that you might need to look at resource. I know in our PHO we've got access to funding for this. Hopefully in your resources from your PHOs, you'll have the same and do some internal referrals to your mild to moderate programs or your health improvement practitioners who could work at the lower level as well. So without knowing your environment, I'm not quite sure what resources you've got.
Thank you. And there's a few people just hopping on to say that MedTech is now integrating with the youth chat.
Oh,
so
yeah.
they're always updating these things and moving them along. So it looks like they've made a little bit of progress in that area.
Thank you for that. It was a couple of years ago that I last looked at it, and that's why we chose not to put it into our program. So that's really good to know, and I will revisit it.
Thank you. And then we've got, hello, do you get the parent out of the room or ask the teenager if they are comfortable with the parent in the room before starting the head's assessment?
And that's a really good question, because what I find, if you ask the young person if they're comfortable with the parent being in the room when you do the head's assessment, they'll say yes, every time. And they're not always comfortable with some of the questions we will be asking, because not quite sure what you're going to ask. So what I talk about when I try and do this is, not that I don't give them the option, but I say, look, because you're 14 now, you are not a child and you're going to be an adult soon. So you do need to learn how to use our services. So what we always do with our young people is we offer some time together, and I'd like to see you on your own for a portion of that time. I'm going to reassure you, mum or dad, that what we're going to talk about is going to cover some issues that are pertinent to young people's health and well-being, and that might include some mental health, sexual health, and cigarette and alcohol use. But if there's any risk, I want to reassure, if there's any concern, where I will be, we will share information with you if there's any risk or real concern. When I say that, it's about the harms again. If there's any danger or any harm to your young person, we will be talking about that. And most parents don't mind leaving. You get some people who'll say, well, I want to stay in. And that's where you might need to navigate and negotiate or review how you're going to do the assessment. Really, really rarely do I get parents objecting. As long as you reassure them that you'll bring them back in and will provide feedback, and it's with the young person's consent what you're going to talk to. And it's all about your communication skills as well. But you'll sometimes get parents that they're adamant they're not going. And I would be very mindful about what I covered. And I'd be saying, I'm going to ask some pertinent questions about your sexual health now. And this might limit what I might talk to you about because your mum's in the room.
Thank you. Have you heard of the app SPARX? SPARX.
SPARX, yeah, SPARX, yeah.
RNA, thank you. So SPARX.
SPARX, I did cross my mind when I was doing the mental health. So that's a cognitive behaviour game. It was developed in New Zealand, and it's got a New Zealand lens to it, which is really good. But excellent for young people. It's a game. You pick your avatar, you go on a quest, and you're given challenges. It's all around your it's all about cognitive behavioural change. So it's giving you choices, and if you should take a poor choice, there's a consequence. You can see the consequence, and so it's an excellent game. It's an excellent game to encourage young people to use. It's free, it's accessible, and I've used it actually with young people in the clinic. I've got them out in the waiting room because they haven't got access to it, and then one of our computers playing it, and then I can check in with them at the end of it and see how they're doing. So it's a great game. And it is a useful tool. I have to say it does work better with younger people because the older adolescents are so much more sophisticated in their gaming style. It does probably need an update.
Oh, thank you very much, Maria. You've managed to make it through all the questions so far today. And I just got one here that Mobile Health will help us with, but just so you're aware that there's a lady on the lead for the ADHB Youth Health Improvement Project. And she said that this presentation would be absolutely excellent for them to share with their Youth Champion Network. And so she's going to try and liaise with Mobile Health about that as well. So that's another little feather in your cap that you've got that far. But yeah, you've had people from all over New Zealand and all walks of life, from nursing to GPs to radiography to maternity, sexual health, diversional therapists. And so a huge range of people getting your message tonight, and will hopefully help drive and build on youth management going forward. So
I think it's excellent. Physios using this tool in their physio consults would be brilliant with bigger reach to males.
Yeah. So no, thank you very, very much for your
welcome.
time and energy this evening. It's been well received, and yeah, can't thank you enough for giving up your time.